morning again. We welcome you from our Mount Sinai with our cath lab, the usual, the frequent, I would say, flyers in terms of myself, Dr. Kini. And then we had two fellows, Tushar and Jaramjeet. And then we had Tech, Asif and Hakeem. Then, of course, nurses, Ashley and Will. All common faces, which is good thing. And imaging is Kiski. So with that note, this is our, I think, the episode number 16th or 17th of the Meet the Master, Learn from the Masters. Today will be the discussion as well as the case will be of the rota cut approach for plaque modification. And moderators are, in the past, I actually did not put the expert panel moderator, but in the going forward slide, I always will put our moderators and expert panelists, Aftab Khan, Dev Srimal, Manoj Chopra, and Ripen Gupta. So welcome all of you from our Mount Sinai. This event is sponsored by Boston Scientific India and of course the ESCC Jaipur and Mount Sinai Fuchs Heart Hospital, New York. We are both no disclosures. So this is the episode number 16. As you know, we have been doing every other month for last 3 years now. This is a 65-year-old male who presented with class 3 angina. He had a known CAD, multiple PCIs of the right coronary and circumflex, normal EF, control hypertension, hyperlipid, no diabetes, SAQ score 45. As you know, SAQ is the basically angina equivalent, their daily activity. 0 means no symptoms, 100 means no symptoms, 0 means severe symptoms, so in between 45. And then we always now will be presenting these 4 risk factors, chemical risk factors, the A1C, LDL, CRP and serum creatinine. Which are all good for this patient, and ejection fraction has been fine. He has been on good medical therapy, as you can see, based on our lipid levels and so. And then was on clopidogrel, and they basically cath revealed 3 vessel disease, and we'll show you that. Of the 2 vessel, we took care. Patient did not want to have surgery after the 3 vessel and high syntax score. We had a high team discussion. Patient had been carrying out CAD for a long time, did not want to have surgery, so we took care of the right coronary and ISR of the OM2 using the cutting balloon and Synergy DES. And then what I did is I changed clopidogrel to prasugrel. As you know, we have papers both in JAK intervention and Euro intervention that our strategy that after the patient with a high risk, if they are on clopidogrel, we give 30 milligram load and give 5 milligram daily prasugrel if weight is less than 100 kilo. More than 100 kilo, this guy's weight is 112, so it's 10 milligram, and those cause less bleeding. So we don't go with those numbers 65, 70 years age and so unless there is a complex bifurcation left main or more than 3 stents or weight more than 100 kilo, they get prasugrel. Many times we'll give prasugrel for 1 to 3 months and then downgrade it to a 5 milligram. And that to me has been a very good in terms of lower mortality, lower bleeding. And we know that ISAR React 5 actually showed prasugrel better than ticlopidine and ticagrelor, but we never saw in our studies. So this case, now question comes down to is, as you see, that patient did not have any imaging test and directly went for angiogram. And actually, you know, the latest European Society guideline of chronic coronary syndrome put this kind of very high risk cases that directly can go for angiogram. You don't need any test in between. And those are symptoms despite guideline directed medical therapy at low workload, prior PCIs. Patient with the prior PCI having symptoms, you can directly go for angiogram like this case I've had. You do not need any functional study, but also, as you just to emphasize on this point, the CTA has become class 1 in any time you're thinking about the CAD. If very low likelihood of CAD less than 5%, then it's fine, but otherwise CTA is a primary treatment, the first line therapy now for the testing for patient with workup of the CAD. So this particular patient, I just want to say, we'll show you some angiogram, appropriateness point of view, 1 vessel disease is appropriate, has FFR positive. Anu, can you show the angiogram to them? Yeah. So this is the right coronary.
So EF
good,
normal.
Yeah.
The right coronary stent looks okay. And this is where we are. Without any dye, you see tram track calcium. We are hearing ourselves.
Yeah. So, okay.
This is the cranial view for the LAD.
Looks like some left main disease now. It was not there before. Or is it 7 French
No,
catheter?
I think 7 French.
Okay. But look at the LED. LED has a positive FFR. And now can we show the circ lesion which we did?
Oh, oh, you did. Wait.
Yeah. It looks
Just
like
trying
some
to
LED
find.
left main disease now. So you remember sometimes that happens, and I'm sure you guys have seen also that initially was none. Patient comes back because of the guide-induced trauma. Then you start having some left main injury and left main disease. So this clearly is you have the left main disease here, which is very troublesome. If that
Yeah, it could be because there's some damping also, some
uh,
ventricular rise. Yeah.
and always when patient comes back, we try to see the follow-up, uh, take care of the vessels, what angiogram-wise, whatever you have done before you go for intervention. So let's talk about it, that knowing that this calcium is good enough on the angiogram for most of our panelists, or you think you'll have to make a diagnosis on the CT, on the IVUS in this particular case. Now, many times we know that CT tells you also the calcium score, the lesion wise, but should we do the IVUS here to make the decision, or it's a good enough? I think that's a part of the discussion we can have before we go on further. Yep. Any opinions? Yeah, tell us and know what you did now.
I actually, even though it looks moderate disease, right? Actually, mid LED. You saw the wiring was okay. That was just a run-through wire. Not easy to get the fine cross down. I was planning to just change to rotawire and then decide on rotational atherectomy based on angiographic calcium. Because I'm not sure if what do you want to do?
Let's bring the rotor wire.
Yeah.
So you want to do, if you need IVUS on the rotor wire?
It may not happen, not easy. Let's see. Get me the
Yeah,
rotawire.
you know what? They have to fix up our audio visual. We cannot hear them well, guys. There's no,
And we are hearing
Can you hear
ourselves.
me
and
now,
we are hearing
Dr.
ourselves.
Amit Sharma?
Yes.
Uday Khanwalkar here.
Yes, Uday, yes, my friend. I can hear you very well. Yes.
Okay, fine. So you have got a wire across, and now you are going to exchange it with a rota wire.
Yeah. So question is, to me, I think it's a tight lesion, positive FFR and calcium. I think it's reasonable just to do the rota first, 1.75 bar, and then get a 1.75 bar ready. And then you decide about if you want to do the imaging, because this is that group. Keep
Maybe
saying what you
trouble.
want
No,
to do.
no, I do not want
Or
1.75.
1.5, that's fine. The 1.5
Okay.
plus cutting balloon, yeah, that will be okay.
I think, let me tell you.
Yeah.
The way, there's many times, decision of the burr will depend how the wire movement
1.5
happens.
bar.
So it was not easy just at the level of the septal. After that, you see the LED where the significant disease is.
Yep.
Can I ask you one question here,
Uh,
please?
Sure, yes,
and
always.
I would go to 1.5 bar.
Okay, you are deciding on the basis of angiography about the burr.
No, keep going.
Would you like to do imaging first and then decide what system you want to use?
The system basically will be that atherectomy or no atherectomy, right? That's one. Second, in the atherectomy, do you need to use orbital versus rotational? That will be the question. But I think based
Yes.
on the Eclipse trial, we'll be less inclined. We actually at present in Mount Sinai, we used to have about 85% rota and about 10-12% orbital and 4-5% laser. And laser basically for uncrossable lesion and undilatable ISRs. But in this particular case, based on the data which we have, Eclipse, otherwise also would have done the rota, but I think it makes it a more point now of using the rotational atherectomy for this case on the angiogram. And this is the question I did ask earlier, that should we try imaging now, or there's enough calcium? The way wire moved, I think I will be happy, okay, to just do it, do the one run of the 1.5 bar and then decide, then do the imaging, because likely it may not go through. Look at the tortuosity. We know that, and of course, anytime you cannot go through is called as a severe lesion, but I think angiographically is good enough to decide. And just to answer that question, that do you decide based on the imaging versus directly, that just by the angio, we actually did the trial called MACE. And May's trial, when it came to the severe calcium, actually wiring alone is causing ST depression. Guys,
Not,
show
no,
the,
no, 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 not
on the
even
one
that.
side,
This
show the
could be
EKG also. Huh?
This could be the left main.
Yeah,
And then he's moving a lot.
yeah, and it's moving. We had to have patient, just show the hemodynamic on one side. Yeah.
Yeah, I think it's left main is significant.
So left main looks like significant. See that dampening at the ostium.
Okay, let's do that.
Yeah.
Yeah, please go. Okay.
Good. So left
Ready.
main definitely has progress, which was not there before. But it's a more of ostial. And remember, the ostial as well as the low syntax score left mains
Pull the wire
has
back.
not become, have become the part of the class 1 now, if the European guidelines, even for the left main.
Wire back.
Yeah, wire is very
Yeah,
calcific. Yeah, so we keep it at this level. The wire should be in the main lumen. Can curl up is not a problem, but try not to get into the small branches. So we are going to go with a rota, and then we do the IVUS after that. So that is the plan at this time.
Okay.
Yeah.
Kiski, your slide on that calcium and this and is there or no?
Okay. It's a 1.5 bar.
So we are doing the 3 steps. First is the knob. You move backward, forward. Any tension between the Teflon sheath and the bar is gone. This is moving backward, forward at the proximal, LED. Any tension between the wire and the bar is removed. So last we will have on the dyna just a little tap. Okay. And now off dyna, we are about 150,000 RPM. We're going to start.
Algorithm.
Yeah.
How much?
See that? Turn. Wire bias. Okay. So what I want to do is just let's stay there, right?
So, yeah, clearly there is a wire bias in the mid segment where there is not a tough lesion yet.
Yes.
The tight lesion is further down. And it's a 150,000 speed, and actually it has gone down. So we need to go up to a little more speed.
No, I would not. Not at the bend. The question is that
Don't
that
take an
kind of wire
angiogram and see.
bias with this thing, I would
Left
not
main
want
out.
to go. Yes.
Yeah,
Could
definitely the left
perforation.
main is creating a lot of trouble for this patient. You
That's
see the
one,
dampening as
and
well
that
as
kind of
EKG
wire
changing.
bias SS we could get into.
Okay.
Risk of
So let's just take a quick picture that we are okay. Yeah.
Oh, not even that. The wire is in the small branch.
There isn't that. That's okay. We'll move it later by the time we go there. So wire is in the 4th diagonal, which is okay right now, but the left main,
Yes, I don't
the
know.
bigger issue is the left main. So what do you do, if that remains, you might just come back and put a stent in the left main
Hello?
and then do the rest of the rota later.
Hello?
No,
Yes.
why it's going
Yes.
down?
No, I just
Speed.
moved. Yeah.
Speed.
Yes, any comments? You want to go to small bar?
You know what? Let's.
This was the floppy wire, right?
Yeah. Yeah.
Let's take it out. Okay, see that this bar did not make that curve. Yeah, any questions from our panelists?
Hello, would extra support wire help us here?
Well,
No, the floppy wire.
Remember extra support, yeah. Question is, remember extra support will definitely give rise to more wire bias because of stiff nature. And I think it did not cross because of the wire bias situation. So question is, to usually yes, you bring it to the lesion, and if it does not go, then you have to go with the 1.2, the extra support wire. But we thought here we'll go to 1.25 bar.
We want to image the left main and just because any time
Yeah.
the guide is
So
touching,
let's do the,
he's
what we do
having
is now we are
EKG
going to
changes.
image the left main and stand the left main first.
Yeah.
I think that's what we need to do. Because every time our guide goes in, patient become very restless, hypotensive, and so. Good.
No other thing, then do we just do balloon and stent?
No, we'll do 1.25 bar. Yeah,
1 to 5 bar you can do now, no?
that's what I just asked.
Okay, let's do 1 to 5 bar.
You want to stabilize the left main or no?
No, because I
Okay.
think once you stent it, we may have issue anyway with the. Okay, 1 to 5? Yes.
Yeah. So you saw that. Let's take one picture. Can we take one good picture? So what we did, so and not did, yeah.
Go. No, I says left main. Look at that.
Yeah. Guide out. Guide out again.
Yeah.
Yeah. So you see that left main definitely is a big player here.
Can discuss that algorithm.
So now coming back to the wire, that extra support wire will make you to deliver, but problem in this tortuosity, see this, you have to, once you put, you try to detach, no, that means you are done, good. In this particular case,
そこ超えなかった。
the extra support wire will cause more wire bias, although it looks like okay here, at this time, this angiogram, yeah, coming out.
No, flush. I don't see the flush.
And the wire is still in the branch. So I would say the use of extra support wire in this situation will be that we bring the bud to the lesion and it does not cross. And you have gone to 180,000 RPM, increase the speed. That's what first thing you do. If you cannot, and then if we still cannot do, then only you go to the root extra support wire. So now we are to 1.25. Good.
Okay.
We are good. 150. Now we are going with a 1.25 bar. And we are going to keep a 3-0 our Wolverine also ready.
Oh, wire.
1 second. Yeah. So wire has actually, because in order to take the guide out, wire has made the curve. Sometimes it's very tough to see. Let's magnify. Where is the wire now?
Pull.
Which are doing. So what you do is, once you have made a loop, you just pull the wire,
Yeah.
and it'll go. See?
Yeah. Now you're
So
good.
the wire pull, as long as you do, guide has come out now. Rotate the guide, put a bud inside. The wire pull has taken away the loop in the aorta. You know, patient is obese, very tough to see the wires. Many times you can only see it on the cine. Yeah, good. Let's go again. Okay.
So the thing is telling us not to do
Wow.
this route.
We may have to redo it, right?
Wait.
No,
I
we are good.
think we're
We are
okay
good now. Yeah, now we are okay. So see, you saw that how loop we are able to pull and push, and disengaging the guide, we are able to. Good. The guide, again, that's fine. Yeah.
Pressure is low.
Yeah. No, this is all dampening. Yeah. Good.
Earlier, did you give some neo? No? But the pressure was high at 200 earlier. Okay.
Good. Okay.
Okay, we'll start with 1 to 5 now. Okay.
Yeah. So it kind of jumped at that lesion, but
Okay, I think it's done.
just polish.
No, we did enough. Don't do more.
Okay. Good.
Come out. Get me the run through. So now we'll use our workhorse wire run through, go side by side, and IVAS the left main.
Sure.
Before that, we'll take some picture, angio, to see what the rota has done. Okay, done. You want to take a quick angio?
Yep. Go.
Okay. Okay. So far.
Okay.
So I think the most important teaching point is, if you look at the vessel itself, we would have said, yes, I think you need 175 bar, because you want the burr to artery ratio 0.5 to 0.6. But then the way the vessel tortuosity is and the difficulty in wiring, that is one which told us that you cannot go with that large size burr. So we've downgraded from 175 to 1.5, and then even with 1.5 wire bias in that mid LED at the angle, we were having an issue. Then same thing, we tried few times, 3-4 times, it did not happen. So that is another one telling us, do not advance or do not try to push the burr at that level, because that would have caused a perforation there. So then downsize again. So I think this is an key teaching point in this kind of cases.
So they
And we did not. Yeah. One say what?
face is back.
Huh?
Say what?
Their face is back.
No, I know, I saw that. Yeah. So question is also second point. We did not show you the console. I mean the console of this. Once you drop 5,000 RPM, empty triangle yellow comes. You drop 10,000, it's a full yellow triangle. If more than 10,000 becomes red. So it was just touching red few times. That basically means that you are having so much resistance at that angle. Don't push further. It's going to cause a perforation.
It was not
Rotawire,
the,
take the rotawire out. Yeah.
no, let's see. We may need for the IVAS to reach there.
So it was not the lesion, it was the angulation. Okay, now we are doing the IVAS.
Sure.
IVAS basically for the LED also, but more importantly for the ostial left main.
Sure.
Ostial lesions are very notorious. We know the OCT is not good, but even IVAS many times is very tough because you have to disengage the guide and really see it.
Okay, so let's see how far IVAS will go. Again, see that?
It stops
Separation.
there. But I'll take the rotawire out.
No, SS. Okay. I think that's how far you want to go.
That's it.
Okay, good.
Yeah, good.
Start iski.
Okay, can you
Oh,
flash a little bit? Sorry,
oh,
kind of dark
No,
image.
wait 1 second. Don't do that.
Yeah, great image. Okay, start pullback. It's a pullback speed 4. It's kind of a fast pullback. Yeah, 360 calcium. Eccentric calcium.
Is it a stent there?
Yeah, looks like that's the stand. We didn't know the information. So now the left main, it's all still, yeah. Oh, sorry, this is the left main.
Okay, but left main looks okay.
This all looks fine. Now come to the proximal left main, eccentric, oh, here, stop it.
Okay.
So I will check first the proximal left main area.
Okay, go to the left main. No,
Yeah.
wait. I may want
It's
to do
not
the
the
left main
perfectly
again.
coaxial. 1 second. 1 second.
Did you get the ostial left main? Do you want me to do manual?
Yeah, that's very helpful
Yeah.
if you can.
Okay, we could not see it well.
Okay,
I'm going back to the left main.
Ostial segment.
sure. I check the image. Turn into a guide.
What is this? And get
Okay.
a 330.
Ostial left
balloon
main now.
first.
Can you
Your
flash
type.
leave it? Thank you so much. So I do manual pullback. So you can manually
Okay,
pull
I'll do
back.
the manual.
Yeah, you can manually pull back. Can you flash leave it? Sorry, can you
Okay,
flash leave it?
Okay.
Thank you. Perfect image. Yeah, you can manually pull back.
Okay, I'm coming back.
Yep.
Keep holding on your flush. Flush.
Okay.
Yeah, some eccentric plug. But here is
Okay, that is
area.
ostium now.
Yeah, now area is okay.
There's a
Yeah, a lot of plug. It's true.
yeah. So this
Yeah.
it's not a lot
Okay,
of
I
fat.
will stop it.
Yeah. Okay.
1 second. I will check again. So come to the end. So it's true.
I
It's not
think
the.
it's eccentric plaque, but area is okay.
It's true. It's not perfectly coaxial, like approximately area, but it's more than 6 at the ostial left main. It's true, a lot of eccentric fibrous plaque, but area is looks more than 6. So by iris, it's
Borderline.
like we can differ. Yeah.
No, you just got 6.1.
Yes.
What
Now
do you
here,
think?
see, you could be less. Go 1 or 2 frame. Go. Keep going. Now, LED first. Go little frame by frame.
Oh, one
There was
sec.
some
Okay.
frame was little
Sure. So
of the left main now.
sure.
We are just basically evaluating the left main. Yeah. No.
So
That's ostium.
yeah, actually, this is half of them is aorta because
Yes.
yeah. So
No,
we
no,
can
Come
don't
back
count
a
that.
little bit.
No,
Yeah,
sure,
you're
sure.
doing true ostium, but that's a come back a little bit. Come back a little bit. Back. Ah, right there.
Yeah, look at
Okay,
that.
now you create the circle. Yes.
Yeah,
Mm.
like this area is still more than
But
6.
I
very
think we could
eccentric.
call it 6.
Very eccentric, yeah.
Yeah, eccentric fibrous plaque. Left main doesn't have much calcium.
Okay.
This is
Now, right now we are putting a 3030 high pressure balloon for the mid LED. And then we'll talk about the diagonal.
I think our
Question is with the left main being there, I think we may just skip the diagonal strategy.
yes. Other question, Kiski,
Yep.
where the mid LED, you
Yep.
know, is there a stent? It looked like a stent there.
Yeah, you are correct.
Is there a
correct.
stent? Because
Yeah.
as
Yeah.
far as the
Look
by
like-
report wise, no.
In
It
the
looked
mid,
like a stent.
yeah, this is like a
Yeah.
artificial dot. This
Yes.
is a stent.
Stent?
Yes.
Yeah. This is a stent. Mid LED has a stent.
Down.
Wow. You have to go a little distal. The history wise was in the CERC and the RCA. But I'm sure, patient many times goes to few hospitals and may have received somewhere else.
So, I think we do 3O and post it. What do you think, right?
No, we can take a,
3,
48.
5?
48.
I don't know, 48 will make a turn.
No, but we get a, we get a Godzilla. Now there is a
Okay, good.
disease after the diagonal also where our rotawire is. What do
So,
we do? Leave that alone?
I would leave that. And then prox LED, I think we should leave alone. Prox LED, we are okay.
Yeah.
Yeah,
Osteo
yeah.
LED is like area is like a 7.
Yeah,
Eccentric
9.
calcium, but area is okay.
Yeah, that's a mid. I mean, prox LED looks good. I think what we do then,
Okay, let's take a picture.
but if
Now,
you need
how
Godzilla-
much calcium was in the tight lesion of that LED? That's the question, right?
Sure.
You said, I think it was 2 quadrants, right?
Yeah, I mean there is also stent, and actually mid and distal has separate tandem stent, and between that two stent there's like a 180 to 270 calcium
Yeah.
native cut. Some part is 360 calcium.
Yeah, now.
Wow. And now you can see the stent.
Yeah,
We thought it was,
But we thought all calcium. I think the rotawire we can take out and let's put a Godzilla and put a long stent. First we do a cutting balloon, 3.5. Yeah.
3O.
Yeah.
They want synergy.
One area.
48.
Yeah.
3 OSS?
3O48 synergy.
Dr. Chavin,
Any
this is
other? Yeah.
Prasad here.
Yep.
Yeah, with the left main nostril disease, would you be happy to take the Godzilla there, or you'd be a little worried?
Yeah, then we'll avoid. Yeah, you're right. The question is, or should we put a stent in the left main first, but then it has to project outside.
No,
There's always a chance for deformity. So I would say that let's see if this balloon can make things a little trackable.
But I will tell you 48 will have a hard time getting it down.
Yeah, but I can tell you, we saw that. It
Yeah,
was.
not
Let's see,
easy.
the cutting balloon will give us the area idea
see?
whether even this is not going.
Yeah.
This is our Wolverine, 3.25 Wolverine. You want to cut there a little bit because there is a calcium there, right? There is a calcium in the proximal LED also, circle calcium.
yeah,
just
180
find
eccentric calcium in the
That's
block.
where we have trouble. See that?
No, but there's no disease.
No, there is a disease. Okay. You know what? Let's spot, knowing it was so difficult, wiring, rotablation. So let's re-evaluate our angiogram again. And that's what I do many times. Let's go back and look into it. We know that lot of calcium. See that? Lot of calcium, severe calcium on the angiogram.
No, what he's saying is where
Yeah.
we are having trouble is a stent.
No, there.
Yes. Kiski, you see the septal, right? Big
s-
septal. There's a stent before the septal.
I'm talking about the proximal at 1 o'clock, 12:30 position. What is
Yeah.
happening? That's where we had a trouble. Look at that.
yeah,
trouble was at
before
the
the
stent.
occluded diag, there's a native calcium lesion.
Major calcium, right?
Yes. After that occluded diag, there's a stent.
See, that's a
After.
stent.
No, that's the after.
Yeah.
But what about the before? Anybody appreciate that lesion before?
Yes, that's the eccentric calcium lesion,
Yeah,
native lesion.
7.7.
Dr. Kinney,
7.7.
this is not correct. The
okay,
AI
okay.
sometimes fail this kind of calcium lesion.
Yeah,
It's a
4
borderline, like a 4.3 area,
Okay.
but eccentric calcium native lesion.
But why then even with the 2 wire there, our Wolverine even the 3030 had a
because
lot
the
of trouble.
stent is creating a problem. It's a stent creating issue there. Look at it. We are hitting the.
Yeah, and a stent is also underexpanded.
I think, sorry, this is
Yeah.
Dr. F.I. here from Chennai. I think
Yeah.
the balloon is getting stuck on the proximal edge of the stent because the
Yeah, we
lesion,
know. That's what we are saying. Yes.
So-
that's probably the wire bias also causing the problem. Maybe
Take the rotor wire out and maybe here, let's take the rotor wire out and see if it goes.
Which
Leave
one?
this there, take the rotor wire out.
Not going to go. Give me a regular balloon. Let's dilate that area.
So
And
Okay.
if we
maybe
have
another bloody
1
wire to try and see whether that will just change the angle a little bit for your
Yeah.
Wolverine to cut through, go through.
Yeah, so I think what we'll do is,
get us a 3.5. Then you're going to strand that area
yeah,
because borderline
no,
anyway.
we are going to do.
You want 3.520? 15.
Yeah, that's fine. Yeah.
3.515 high pressure.
But I think we should put a fielder wire because fielder wire in this wire bias will create less issues. Give us the fielder wire. Yeah. And let's do all the work on the fielder wire now and take the rotor wire out.
now,
Good.
I'm Ajit from
Yeah.
Pune. Now we have
Yes.
1.5 burr on table. Can we, upgrade to 1.5 burr? No, not really needed.
Well, I mean, the point is, I think that the trouble here is that the proximal tortuosity and calcium and proximal stent edge. So question was, that area we were never able to take care of the rotablation point of view is because our rota burr, we kept on thinking that it's going because the wire bias is not going further. It looks like now is the stent there. Angiographically with that calcium, we couldn't see the stent. Now we had to take the guide out again.
First, let me wire.
Yeah. So just now what we are going to do is run through is a little stiffer wire. Now we go to our hydrophilic, the fielder wire, and we do the work on fielder, and hopefully this wire bias, as we talked about, will be less. 3.5? Yeah. Yeah. Actually, you know what? I want to go back with the Wolverine now to see whether it tracks better on the floppy wire. Give that Wolverine back.
Yes, let's just do what is going to
No,
work.
but I know. We have to show it. Yeah. Good. Okay,
This
good.
guy with left main disease and
Yeah. So let's try the Wolverine on the floppy wire. Same thing there. See that we didn't push anything. We don't cause any more guide injury to the left main, which is already there. And there we can always put a left main size is what, 5? We can put a 4.5 Megatron, right?
Yeah, you can put
12.
4.5. Yeah.
Yeah, 4.512 Megatron. Or 4.5 or 5? I think 4.5 will be okay.
Yes.
Okay, so just to say everyone, what we have done now, we have put the fielder wire and we are going now with our Wolverine on the fielder wire to see that the whole wire bias issue is less. Good, definitely good. Okay, very good. We are able to demonstrate that in this case. Okay, good. Let's do it now and then we'll go. Once you are there, it will make movement further. And you can leave the side-by-side wire with the Wolverine, and Wolverine you can go to 16, 18 atmosphere without any problem.
okay, down.
Now, question is the rota cut approach. That's our one of the focus that we had done. Actually, we thought this strategy of the rota cut will give you better lumen. And we have 60 patient randomized trial showed identical with a rota high pressure versus rota cut rota cutting balloon with a lumen minimum stent area about 6.45. So there was no difference. Let's do it here. Yeah, this is the one. We do little proximal. And you can go easily 18 atmosphere of the Wolverine. Old one, you cannot go more than 12 because they burst, ruptures. So 18 here.
Okay, down.
Good. Now see if it goes further to, if need to be. Yeah. See, Wolverine making good turn.
I know, but it's not making that turn further down. Let me see here. Okay, yeah.
Right.
Okay, good. Go up here.
Is there any question there? Yeah, so we have to go inside the stent. We are still not in the second stent, right? There are 2 stents in the LED?
Yes, tandem stent.
Yeah, one here
Yeah,
and one
and one
here.
there, yeah. So let's try to go inside there.
I think if
Let's
I
not
make
do
a
this.
comment,
Yeah.
I think it's the imaging has really changed the strategy. I mean, normally
Yeah.
what people would have done is increase the size of the burr, but here it could be quite dangerous if you increase the
Yes.
size of the burr.
That's
Having known
correct.
that the stent is completely
3.5
underdeployed at the proximal edge of the stent, that could only upgrade the stent and cause more problem to get your future strengths down. But I think by doing the imaging, we now know that we can upgrade with the balloon and go with the stent rather than going with a higher burr, which could actually cause more trauma and problem in the delivering the newer stent.
Absolutely, and actually very important, and that correspond to our activity what we saw. We were very much surprised that the burr would not go beyond that mid lesion. Remember that they started getting a more than 10,000 RPM drop at this level. And it turns out to be now it's because the stent is strut. And again, you know, we could not have figured that out based on the calcium so much. And second, we actually, patient had 2 procedures done at Sinai. So this third one probably was done somewhere else. We have the RCA old pictures and they were done like 10 years ago. And so
What
LED
size
must
is
have been done 3.5. This 3.5 now.
Where? Yeah.
Yeah. Let's open here.
Dr. Sharma,
Yeah.
what is your opinion about using IVL in such non-homogeneous calcium?
Okay, we have the all experts on the imaging and non-homogeneous calcium. The IVL will work or not. I would say the IVL we should work if we need to do. Only my question will be when we have so difficult in delivering our Wolverine. Yeah, let's go up here, this area. No, proximal. Let's go to the proximal area.
No, this is it.
Yeah, yeah. So
Because
with
we
that
are
it will
going
be
there,
very
yeah.
tough that IVL, current IVL. You know, there are 3 companies working on various IVL devices. One of them is laser. Will be starting called fracture trial as of January. So many other more flexible IVL will be coming in the market by year end next year. Current IVL, I would have very big doubt. I don't know what you think.
This is 3.5, right? You
3.5.
want to do
That's
it
okay.
here?
We can open here. Yeah.
Okay.
Moderate. The current IVL will go because regular balloons having trouble, our Wolverine having trouble, ruptured.
Rupture.
It ruptured already.
I think
agree
if
with
you
you.
want.
I agree with you. And if the left main was not there, you could have used a Guidezilla or equivalent.
Yeah,
and
that
taken
is
a-
true. Yeah.
No,
Both
if
wires
you
are
want to
pulled back.
stent this, you'll need a Godzilla. You want to take a 6 French and just do it?
No, but let's put a left main stent first.
If you put a left main stent, it is an ostial left main. Part
I
of
know.
the
Believe
will
me.
be-
We are,
will it
I would
create
take the
any problem
as
to
a
take material
let's
down?
have,
that
let's
definitely
have the
will. One by
Godzilla.
one. Huh?
Let's have the Godzilla deliver and immediately do it.
No, but that will cause lots of ischemia.
Yeah, but you have to be fast. That's it.
No, but my question is, should we
Otherwise
just
you'll
try the
not-
stent?
No, I will tell you now. It's not going to make.
Okay,
If you
one
take
second, one by
48,
one.
it's not
Give
going
us
to
the
go.
Trio 30 balloon once again, which we had earlier. Trio 30 balloon once again.
No, 48 is not going to make the turn.
Okay.
Now you want to go shorter stand, we can try. And then where? Look at the disease.
Now we'll go before the diagonal. After diagonal, we'll leave it.
Okay, then
That ever needs a lima, if patient ever needs, so we'll leave that after the diagonal, but we do it before the diagonal. So now we are trying back our 3030 and go to much higher pressure, and we are going on the floppy wire. I mean, the whisper wire, basically, the
Fielder.
fielder wire. Okay, so this is the used one. So we'll go negative. Question is decrease the profile.
Okay, go. No, no.
Good. You have to
Ay,
decrease
ay,
the
ay.
profile inside.
Did you do it with the syringe?
Yeah, we did. No, but we'll do it inside. Yeah. Your wire balloons are going, wires are going haywire. Both the wires. So you have to pull back always in these tough cases. What happened after tough, you figure it out. Now there is a wire perf in the distally because so much back and forth. So this always had to be careful. See, now this balloon went very easy. Okay. I'm going up now.
Okay.
So that's where it ruptured. So we go with a little higher pressure. Ruptured
Oh,
also?
Yes.
Yeah, this one also ruptured, huh? Yeah.
No, no, no. Oh, it's,
Ruptured,
yeah,
ruptured,
ruptured. Okay, down.
Wow. Ooh.
At how many atmospheres did it rupture?
12, 12, 12.
So is there a calcium spicule which is interfering with the balloon?
Or the
Yeah,
stent,
or the stent strut. One
or
of
the
the
stent
two.
stud, one of them.
Dr. Shamin, this is Aftab here.
Yeah.
See, the two
Yes.
problems we face. I think there's a proximal stent that is unexpanded. The proximal stent amongst the two stents, just beyond the curve, there is the proximal end of the stent which is unexpanded. You've done a cutting there, 3.5. I think it's really nice to just do an imaging to find out if we have a good stent expansion. Because the other thing I could think of is to do a DCB there. If you really don't think you can make that turn, or if you already had a stent failure earlier. So, I mean, that is one thing that we could also consider if you have a good plaque modification.
Go back to the stent.
But only large vessel. Remember the DCB enlarged and this stent has been placed. This could be the first generation of
What is
DEF. This is
Again,
the
same?
3 or 3.5. Yeah. 3
Okay.
Yeah, we are going back again with the new 3030. Yeah, so question comes down to that such a large vessel and knowing that it was a first generation DES, what you do? You put another DES or you try over the drug coated balloon. As you know, the guideline is still based on even now the latest trial of the rack cage free, but otherwise also still is that if you have a large vessel, that large vessel ISR, I would still go with the first treatment as a second DES, and unless it's a diffusely diseased vessel, that's a different story. So that case. So now we are going back again with a new 3030. Okay, let's see, this does not rupture. So we're going slowly now. 10, 12, 14, 16, 18.
Okay, down.
You want to go a little further or you're
No, no,
okay?
he's having lots of EKG changes. Let's do a definitive treatment quickly.
Okay. Open the entire area so that we see the stent will go. Yeah,
Okay,
good.
go.
Guide again out. Yeah. Yeah. Every time careful. As soon as balloon goes, you curl back. Now I'm actually at 16. Hopefully rupture.
Yeah, rupture again. That's a stent spicule then.
Yeah, that's a stent spicule. Whether could it be a calcium spicule? Kiski, you want to look into this once again? What is causing the multiple balloon ruptures here?
So after that big bend, after the occluded dia, as the moderator said, there is an under expansion of the proximal edge of the.
I would go with a 3028 synergy first. Short. Not 48. 48 will not come, right? You agree with that, guys?
Yeah, I think so, because by putting a stent, you will avoid this push out the under expanded stent. That will avoid future. You can always go with the post-dilatation balloons with the high pressure.
Will do. Yeah. And if need to be that time, we decide.
We have dilated that with 3.5 Kiski already. Yeah.
Dr. Sharma, one question.
Yeah.
You have done the rotablator. So has the rotablator exposed the stent which is giving rise to these repeated ruptures?
I mean, they could be very well possible, and particularly the proximal stent where it was multiple time our burr was sticking there.
Yeah, but right now the rupture is not happening at the proximal. It's at the distal, which is further down. Yeah. And we have already, yes. So that's what I'm saying. Let's just put one stent and then.
No, this is the short one.
Yes. Let's go.
3 or 20, but let's see if it goes.
Have the Godzilla ready? 6 French, right? Or you want a 7 French Godzilla?
No, 6 French, 6 French, 6 French. So less ischemia. Let's see the test of the synergy. Synergy XD.
Oh, forget it. It's that stent.
Good. Going to make it now. Yes. Take the other wire out.
No, do you want it out
Little
completely?
bit. No, little
Yeah.
bit only.
Pull back. No, some die, so I know exactly where we are. Okay. Okay, yes.
You're good. You're good.
No, some die. Yeah, that's what you wanted. Okay, go up.
Okay, this is the 3028 Synergy XD. I'm deploying at 16 atmosphere. We'll pull back and we'll go to high pressure there.
So you see, we did not take out that buddy wire completely out. If possible, I will advance it further now. When you pull this SDS back,
Good,
okay,
good, good. 1 second here. I'm going very high pressure now. 24.
Okay, down. Tip of the wire is
Ruptured.
gone. No, it did not rupture.
The diastasis.
No, that's okay. That's from before, I think.
Can take the balloon out.
I think, but forget it. This run through is bad.
Get a 32 now.
So the run through is again further down. So, but you want to put 3.5 now?
No, 3 are there. Then you need 3 stents here. Because I don't think we should go after the diagonal. Diagonal is already subtotal, gets the collateral. So we, in this particular case, our strategy changed because of the left main. Let's come out of this.
No, will be 4 stents.
Yeah, 4
32 is not going to cover all the way.
Right. Good.
I don't know. 32?
Yeah. 32, right? What is that?
SS, you want to put hold on.
We had the 48 open earlier. Tell us what we need to do.
No, I'm just thinking, do we put a shorter one because you're going to put a 3.5? See there?
Yeah.
Right?
Mm-hmm.
And this one we put a 3.5, right?
3.5, 48.
No.
Let's try 48.
From where to where?
From the proximal, cover both the lesions now. 48 will cover.
A 3.5, 48.
Yeah.
You're opening another one?
Yeah.
Or you
3
want
or
to put
48.
3?
Yeah, and we'll post dilate.
Yeah.
We'll post dilate. Good. So this is the stent which we originally opened, and now we did not put that earlier, not knowing that it will go, but it went actually. Synergy made a good turn of the 28. Now we are going 48 from the second lesion to our proximal LAD lesion stent, and then we'll dilate with a 3.5 30 high pressure or 20. So I get a 20. All right. Let's see everybody. Will it go? Let's take the vote.
It will.
Have a
go.
3.
Yeah.
Have a 3 or 20 ready also.
Yeah. We'll go ahead.
Stent.
Good. Sorry. All right.
Wow.
48 made it.
We call it a
Very nice. Okay. Now
long.
let's take the other wire out. And we want to make sure that the coverage, because of the stent is inside the dot. Yeah, we are well covered. Actually, we can pull back a little bit if you want.
No, it's an unnecessary. We are putting a.
Good.
Okay.
Okay, going up.
Yeah.
Okay. And then 4012 Megatron.
I think the
Kiski,
lesson.
what's the left main?
Yeah.
The 4.5, actually the lumen,
There is a
4.5,
4.5
the heresy
Megatron.
part
No,
of
The
the
4.5.
You said 4.
No, 4.512 Megatron. Sorry.
The
Yeah,
lesson
that
we learned
mid area
from
not
this-
fully expanded. Yes.
Excuse me. The lesson we learned from this is a very good preparation of the bed prior to taking
Yeah.
the stent, which facilitates taking the stent down the calcific lesion.
That is absolutely correct.
It's not coming out easily.
Okay. What is this? 3.5? Okay. Now let's post dilate 3.520 and then we'll take some pictures and then you put a stent in the left main. Guide is again doing the Kathak. We don't need to advance the wire now. We leave that wire.
I don't know. Let's
We don't
see.
need that wire now.
Okay. I don't know if it'll go. You want to take a picture?
No, just dive it.
And then your length 12 is good. 4, 5.
Yeah, 4, 5, 12 is good. Very good.
I think you are good here.
Yeah, good,
Okay.
good.
Now we are post dilating with the 3, 5. Good. This is 2 layers. Okay.
16.
Okay. Down.
Go a little more further.
No,
That's the area of the unexpanded stent earlier.
Yes.
no. That was proximal, not the
Okay.
distal one.
But let's do the overlap a little more. We have not done the overlap yet.
Now it's not going to go.
Okay, do the proximal.
Okay. Here, this one you can post dilate.
Do you want to do a stent boost to see if proximal edge has been covered?
I
Okay.
mean,
20
angiographically
atmosphere here.
looks okay. IVUS will tell us.
We have a 3O balloon or we ruptured those 3Os? Only 30 is left, right? What 3O balloons left? Because a lot of balloons have been ruptured here. Okay.
How high you went? You really went
20.
high, right?
20. You want to take a picture now and then decide. Yeah, good. Don't take out completely. Let's take a picture and then decide.
It's not going to go a second.
Ready?
No, okay. Wait.
Yeah.
Okay, go. Ay. Okay.
That's fine. That's done good. Yeah. I think that area to me about 130. So you know what? We're going to go same. We are 020. No, 1 second. We may not need 1 second. I'm profiling this balloon. Okay. Now go again. This balloon should go. That's the way we use quite a bit in our India. Profiling. Good. Good. That's all you needed. Yeah. I'll go moderate pressure here. 16. Earlier we went 20. Should we go further? I think that's it. Good. Okay, now left main stent first or we do the IVUS?
Let's stand the left wing.
Okay.
So 1 IVUS.
Good. 4.512. All right. We are getting to the timeline. We actually have 5 more minutes for our start our lectures, and 5 minutes should be good. Left main. This is the Megatron. As you know, XD, Megatron, everything is available in India now.
IVUS is ready. You have it.
So clearly, once you are the ostium, you have to find your best view. Like this is a very good view that you have to cover the proximal part ostium. 1 or 2 struts have to be coming out, which is okay. You want them to be out.
So the first one is
Can I interrupt you, Dr. Sharma, here?
Always, my friend. Yes.
Yeah. When you are doing a left main stenting, especially
Yeah.
the ostium, would you like to keep one wire in the sinus?
Yeah, we actually have this extra wire in this particular case. We'll be fine. Leaving it there, that's okay. But the old Zebo technique, we did almost like 20 plus cases, and I can tell you very high restenosis, like almost 14-15%. So we stopped doing it. I know people might be doing it now. I don't know whether you do it now. At one point we did the Zebo, but no good. Now wire we can put here, which is okay, to see that we are at the ostium. We have second wire there anyway.
No.
Yep.
Okay, give me some dye.
Yeah, we're too far.
I know. Some dye. You may not see it.
Advance the wire also, they want to see. Yeah.
No. What do you think? This view? Wait. Okay, some dye. Good, no? This is the right view.
But you have the wire. If you can advance the wire, there's no harm in it. You
For
have
what?
the wire.
What are you going to?
Wire just out of the ostium.
No.
You take a picture.
Yes.
Yeah, looks good. Ready?
A lot of the stent will be.
No, it's
sticking
inside.
out.
Will be
Yeah.
all right.
Okay, go up.
$16.
So this cranial view is the best view for the ostium, but depends on the patient's body habitus. Could be epicranial, sometimes little LAO, RAO.
What is your view about LAO caudal view?
Yeah,
The
for the-
LAO caudal is more for distal
Distal,
left main,
Yeah, let the ostium little
not for
flare
the
in.
ostium.
Yeah, good.
Yeah.
Yeah, we are actually caudal in the, that's a little trouble.
This is a good way to expand. Now what we'll do is once a deflated balloon is there, I'll
Advance the
just get
guide.
the advance the guide on the deflated balloon.
Why not a 8 mm stent, just an ostial focal lesion?
Yeah, very good point. So what happened is, remember there was one paper almost like 15 plus years ago that anytime when they have ostial lesion, the one of the factor of restenosis was 8 mm stents, because many times the stent actually wasn't even there at follow-up. It's embolized. So by and large, our practice always have been, and we can ask other moderators, that we never put, now I would say not never, almost never put, maybe in 2-3% cases because there is a bifurcation issue. Otherwise, we just don't put the 8 mm for that region. Because many times the stent may come out or at follow-up we have to project 2-3 mm of the stent in the aorta, so for that region. So we are not used, and our teaching also has been that if you're putting a stent, put a stent at least 12 mm in the ostial left main. Let's take a picture now and then we'll do the imaging and then we'll go. Yeah.
I
See
think
what's happened to that
melon
stent.
seeding,
Oh, okay.
8 mm can melon seed as well. So I think
Yeah. Multiple factors, yes. Good. Okay. So far, so good. Looks all right. Good. Now, post-dilate with the 5-0.
Yeah, you can.
Ostial, right? 508. Now we can
No.
post-dilate with a 508.
Yeah.
No, it
Now we
would
actually
not.
have the pot balloon. You know, pot balloon has just approved in America also now. But I don't have the 5-0. I have 4-0. So I know it has been being used here. We can use a 508.
No, let's do the IVUS.
Yeah,
If it
okay.
looks good,
All
we are
right.
okay.
Okay.
Wait.
Okay. IVUS.
Yep.
We may have to do 2 runs, Kiski. Come
Sure.
closer. Huh?
Yeah.
Yeah.
That's
Okay.
fine.
Am
Yeah.
I at the distal edge?
Yeah, it's an interest stent.
Okay, wait.
Oh, it's a native.
No,
it's a
out,
native.
out.
Yeah, yeah.
Perfect.
Okay,
You
okay,
close. Okay, start pullback.
Always flush.
It's coming.
Yep.
It's a native.
Go.
Yeah, this looks perfect. Well expanded. No malposition, no dissection.
No.
Good expansion.
There's one
Nice,
area of
nice.
less expansion.
All interest stent. No gap. Still interest stent. Well expanded. Now come to the native. This is austerity. Come to left main.
Good.
Oh, yeah, we stop. So can you do again
Yeah, hey,
Oh,
not
sorry.
done.
Okay.
for the left main?
Okay, now I'm coming back to the left main, okay?
Yep.
And
Hold
then
on.
you have to disengage the guide. Yeah.
Oh, hold
Yep,
on.
sounds
this
good.
broke. See?
That's okay. From there we start. Yeah.
Now, can you see it?
Okay, check the image. Yeah, it's
Okay,
interest stent.
wait. So I'm at the.
Yeah, it's a
No, hold on. Let me come back.
Yep.
Okay.
And you
Now
have
you
disengaged
can
the
try.
guide.
Yeah.
Okay, start pullback. Coming. Blocks LED. Yeah, it's a native blocks LED. Can you flash? Sorry. Thank you. Flash, sorry. Yep. This is a left main stent. Yeah, covered ostial lesion looks perfect. Well expanded.
Beautiful.
So I'll
So we
check
no
the
need
left
to
main
post.
first.
Yeah, let's see the ostial left main. Is it
Sure.
okay? Or do we need to post dilate? That's the only thing left now.
Area is
It-
like a
it looks
13,
okay, it's
14.
no need to
And a
post it.
normal position
Yeah.
for dissection. Area is 14. And a covered osteal lesion.
Beautiful.
yeah.
Two struts.
Left main stent looks perfect. I'll come to the LAD stent.
There was one area of the little under expansion we saw.
You're right.
Yeah.
So this is the proximal edge of the LAD stand and this is distal edge stand. So AI said, yeah, you're right. So
This area.
actually the tightest area is like a 4.3.
Now we should go get our 3.5 balloon here or 3.0.
It's a distal part.
Yeah. Yeah, 3.0 we can
SS,
use. Yeah, they can just do it later. Yeah. So that's the only area we need to
Yeah.
dilate. Let's see the
Other
picture
part is
and
like
go to the
more than
model view.
5. Yeah.
Huh?
Other part is more than 5, very expanded. That's the one focal part under expanded.
Okay.
Good. Let's take a picture. Give
No, we
some
did a
light.
picture already.
No, caudal.
Okay.
Caudal view,
Look
and
at
that
caudal
area
picture.
you just have to post dilate and we'll go and start our discussion.
Okay.
Want to give a little nitro? Stent may dilate with the nitro. Give so much nitro, stent will dilate. Yeah, good. Let's take a picture. Good. Looks very good. That
Doctor,
area we just will post dilate. If everybody okay, you saw it. Beautiful demonstration of the plaque preparing the bed, and then this tortuous calcific, unknowingly two stents, which we did not know by the history, but end result came out perfect.
Dr. Sharma, if
Yes.
you dilate in that small
Yeah.
lesion, which is
Yeah.
appears to be under expanded.
Right, we are going there now.
Yeah, when you are going high pressure, is there
Yep.
a chance of rupture?
That always is that trade-off. You're right. Always there is a trade-off that if you go to very high pressure, and I say that in those cases when you post dilate, my personal experience has been that if you go beyond 20 atmosphere, less than that, no. And if you need to be, this is kind of case, you can just even do IVL there. The IVL probably with the low pressure will expand further because there's so much calcium around, right?
Yes, yes.
It's a calcium ring.
Yeah.
Around. So it will be okay to do even IVL, 3.5 IVL in that area. So low pressure, get a lumen about 6.5 because you want a 6.5 lumen in that area. That is what correlate with long-term, that lower TLF. But don't go beyond 20. Okay, with that note, Uday, you want to start the lecture series and I'll join you in next 5 minutes.
Sure.
And
Please.
thank you very much.